Good evening to everyone present here with us today. This is Shreyan from IGCP. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker doctor for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Madhuri Patel. Ma'am is MD, DGO, FICOG, Secretary General, FOGSI, Editor in Chief, Jogi Honor Clinical Associate, Naurozji Wadia Maternity Hospital, Mumbai. Ma'am is also former professor, PGI, ESIC, Mahatma Gandhi Memorial Hospital, Parel, Mumbai. Now, with the help of ma'am and her wonderful insight, we will be taking a close look on today's topic, which is postpartum hemorrhage. Now, without any further delay, I would like to welcome ma'am at our forum and would like to hand over the session to her. Over to you, ma'am.
Thank you very much for your kind and warm introduction. And I'm going to talk on PPH. Before that, I would like to share my screen. So give me a minute to share my screen. Can you see my screen?
Yes, ma'am, your screen is visible.
Yeah. So good evening to dear friends. Today I'm going to talk on postpartum hemorrhage. Then if you look at the postpartum hemorrhage, it is a serious life-threatening obstetric complication and it has remained one of the leading cause of maternal morbidity and mortality both in developing world as well as developed world. It accounts about the 35% of maternal death worldwide, and we lose 1,40,000 our mothers annually, and the frequency of the death is every 4 minutes. India contributes, unfortunately, about 19.9%, that is one-fifth of the maternal mortality occurs in India, or out of the world mortality, which is very saddening. Most of the deaths are considered preventable, and 98% occurs in low and middle income countries. The incidence of this postpartum hemorrhage is 2 to 4% following vaginal delivery and 6% after cesarean section. So the global incidence, which I was talking about maternal mortality, now look at the global incidence is 11% and 40% die at the level of one facility, that is delay one, that is in clinic or district hospital, and 50% of maternal loss occurs within 24 hours. So PPH is the fastest killers, which is the question to us, and I will prove that it is the fastest killers. If uterus can bleed up to 800 cc per minute, and within 10 minutes, patient can collapse and die. So look at this chart. Of the PPH, the death can occur within 2 hours. Antepartum hemorrhage, it takes 12 hours. Rupture uterus, 1 day to, that is 24 hours. Eclampsia, 2 days, 48 hours. Obstructed labor, almost 3 days, that is 72 hours. And sepsis, almost a week. So PPH is recognized as a quickest of killer as early as in 1991 of the maternal death, which was reality. It was recognized in the 1991. But today also we face this problem even after almost 33 years. So WHO has defined PPH as a loss of blood 500 ml or more following vaginal delivery and more than 1000 following cesarean section, which is in first 24 hours of postpartum. However, various authors reports whatever amount of the bleeding is there. Suppose the patient is anemic of 6 gram person, she cannot even tolerate 100 cc and she can go into shock. So we cannot wait that she has not lost 500 ml, so she is not in shock. But therefore, the various authors label that whichever blood loss is there, it causes hemodynamic instability that is to be considered as the postpartum hemorrhage. So we all of us are aware the causes of postpartum hemorrhage, and the FIGO guideline says 4 T's, that is tone, uterine atony. It accounts for 70% of postpartum hemorrhage. Trauma, that is laceration of uterus, cervix or vagina. tissue, that is written product, completely placenta or a clot or a part of placenta. Thrombin, that is pre-existing or acquired coagulopathies. The patient may be on anticoagulant, that is an acquired coagulopathy. And we divide into primary and secondary. Primary occurs within 24 hours and secondary occurs after 24 hours till the puerperia. So you look at the risk factor for uterine atony. It is due to excessive uterine distension, which can happen in macrosomia, hydramnios, multiple gestation, then anesthetic agent, myometrial exhaustion, that is precipitate or prolonged labor, induction of labor, chorioamnionitis, and prior history of uterine atony. I would also like to add over here that full bladder can also cause uterine atony, so you have to remember this practical point. Now, it a morbidly adherent placenta is taking a toll on our mothers. In the past, in 1999, the rate of PPH in developed country was reported to 1.5, and 2009 it rose to 4.1, and atonic PPH it was 1%, rose to 3.4%. So this morbidly adherent placenta is playing important role of atonic postpartum hemorrhage. So what is happening? The cesarean sections have increased, so there is a gap. The healing is a problem. So in that case, yeah, the placenta get adherent. It can be accreta, that is just adherent to the myometrium. It can go inside the myometrium called as increta, and it can come out of the myometrium in serosal layer of the uterus. It is called as percreta, and if it is anterior, then it can go and sit on the bladder also. So these are the problems we are facing today with placenta accreta syndrome. So now obesity also has been reported by Bolmer and et al. That if the BMI is over 40, the risk of this PPH is 5.2% with normal delivery and 13.6 with the instrumental delivery. So now look at the coagular defects. When the coagular defects can occur in patient, that is placental abruption, what you call as accidental hemorrhage, severe preeclampsia and HELLP syndrome, amniotic fluid embolism, massive transfusion, severe intravascular hemolysis, congenital or acquired coagulopathies, retention of dead fetus, sepsis, and anticoagulant therapies. So these are the risk factors for the coagulation defects. Now, risk factor for the traumatic PPH. It is a previous cesarean section. She can rupture with the contraction of the uterus, then other scars of the uterus, obstructed labor, misuse of uterotonic drugs, and operative vaginal delivery. So these are the risk factor from traumatic PPH. But remember, this can be seen in one patient combination of these like atonic and traumatic PPH all along with the coagulopathy. So you have to remember, we are not dealing only atonic PPH in one patient, you can be dealing with traumatic PPH also. So you have to diagnose accordingly. So what can happen because of PPH? There is hypovolemic shock, DIC, renal failure, hepatic failure, ARDS, and maternal death. So majority of cases, risk factors are not identified. Suppose we see this is a low risk patient, still she can land up with postpartum hemorrhage. But moment we see this is a high risk patient, we remain prepared for the high risk patient that she is likely to go into postpartum hemorrhage. But here the idea is that the low risk patient also can have postpartum hemorrhage. So you have to be prepared for all the category of the patient for dealing the postpartum hemorrhage. Preventive measure can be done before delivery is that you have to correct anemia because anemia is prevalent in our country about 65%, and therefore correction of anemia itself can reduce the postpartum hemorrhage, atonic postpartum hemorrhage. Identify high risk pregnancy and timely appropriate reference. Then when she comes in labor, placing large caliber needle during labor, One pint of blood should be cross matched when there is a high risk factor. But in our city, metro cities like where I'm working, we keep all for low risk or high risk, we keep 1 pint of blood ready for all the patients who are in labor and active management of third stage of labor. So this is a revised guideline of active management of third stage of labor for the prevention of PPH, which has WHO has recommended that clamping of cord, delayed clamping unless the baby is premature or asphyxiated, control contraction if the skilled birth attendant is present, uterine massage is not required if you are giving oxytocin, then you can start immediately oxytocin 10 units intravenous or intramuscular by skilled provider, not the ordinary people. Argometrine, if the oxytocin is not available, but argometrine, we have to remember we cannot use in hypertension as an preventive measure. But if we are treating, patient is not getting under control, then management part we can use it even though she is hypertensive. Misoprostol, if the oxytocin is not available, we can give 600 microgram of misoprostol. Nowadays, it's a common practice that patient in rural area, they give the tablet of misoprostol to the patient, and as soon as the baby is delivered, they are asked to take, misoprostol tablet. But this is, in a rural area where the facilities are not available. And nowadays, the new drug called carbetocin, which is used only for the preventive aspect, that is 100 microgram of carbetocin over IV and should be given in 1 minute. Now look at this PPH. When you give preventive aspect of PPH, oxytocin, it has been reported that benefit for early administration of oxytocin includes 25% reduction in PPH and 50% reduction in the need of blood transfusion. Early administration of oxytocin before placental delivery has not increased the rate of retained placenta. Following delivery, when you give oxytocin, you should continue this oxytocin at least for 2 to 3 hours after delivery, because uterus can go into again atonic. So this once you give pitocin, you should continue this pitocin at least for 2 to 3 hours, especially when you give IV drips. Now let us look at the treatment of primary atonic PPH. That means what is happening, that 70% of these PPH are due to atonic PPH and majority of them are preventable. But now we could not prevent, and therefore we are with the management of atonic PPH. We can manage by medical management, mechanical management, that is in form of tamponade, non-pneumatic anti-shock garment, surgical management, which is conservative surgery, radical surgery, and selective arterial embolization. So these are the pharmacological management of atonic PPH. I told you oxytocin is the best, but if you cannot refrigerate, then the potency of the drug goes away, and therefore we are with the other drugs called methyl argometrine, that also requires, but you can go ahead, you can have 15 methyl argometrine, 15 methyl prostaglandin F2 alpha and misoprostol. So where facilities are not available, we prefer 800 microgram of misoprostol. But if the facilities are available, then we give IV or intramuscular, provided the skilled birth attendant is there, IV or intramuscular, or IV 10 to 40 units, and there is no contraindication for oxytocin. Methyl argometrine, hypertension and PIH, you can give, every contraindications are there. But as I said, in emergency, if nothing is helping, there is no harm in giving argometrine or combination of argometrine and oxytocin, and it can be given every 2 to 4 hours. 15 methyl prostaglandin F2 is also very good, uterotonic. You can repeat every 15 to 90 minutes, but it is not indicated in cardiac, pulmonary, and renal or hepatic diseases. And as I say, misoprostol is the most appropriate dog in a rural area where you can put 800 microgram rectally, or vaginally not possible because patient is bleeding. Rectally or orally you can give. So now there is something called as first response postpartum hemorrhage bundle. It is also called as E-motive. Now, what E-motive stands for? E means early diagnosis of the postpartum hemorrhage, whether it is atonic, traumatic, mixed, retained placenta. What is it? Coagulopathy. That is early diagnosis, very important. M stands for once it occurs, you have to massage the uterus. O stands for oxytocin. T stands for tranexamic acid. IV fluids are there, and acceleration. E again is acceleration of your procedure to save the mother. And you, whatever you do, you have to continue the fluid. And these are the e-motive trial which we are having with Foxy, what you call as Leader Development Initiative Project, and we are doing this. And I would like to stress upon tranexamic acid, that is we are using tranexamic acid 1 gram IV over 20 minutes diluted in 20 ml, which you do give as early as possible in both atonic as well as a traumatic postpartum hemorrhage. Now, if the patient does not respond to your medical line of treatment, that is called as refractory PPH, which you can do aortic compression, bimanuuterine compression, intrauterine balloon tamponade, non-pneumatic anti-shock garment, and you should continue the oxytocin drip, and tranexamic acid can be repeated after 3 hours. So let us look at the rule of 30. What does it mean? There is a 30% of loss in blood volume, which is moderate shock. We cannot say mild shock, moderate shock, and severe shock. Shock is shock. But when the 30% loss in blood volume occurs, then the systolic BP falls by 30 millimeter, heart rate rises by 30 beats per minute, respiratory rate rises by 30 beats per minute, urine output decreases by 30 ml per hour, and hematocrit drops by 30%. So this is a rule of 30, and we can definitely calculate by clinically. So tamponade, it has been reported is successful in arresting atonic PPH in 80 to 90% of cases. It is simple, low-cost method. Minimum training is required, minimum anesthesia required, and no complication reported. Can be achieved by balloon tamponade, and you can use this as an interim relief where you are in the primary care center and you have no facilities. You can use as an interim, use. So you can transfer the patient to the tertiary care or a secondary care where all facilities are available, and uterine packing is not used in revised guidelines of the WHO. So most probably balloon use a Bakri balloon, and I would stress about Shivkar's balloon pack, where I had an opportunity to work with Dr. Shivkar at JJ Group of Hospital under him, and he has, invented this long bag, but it took time to get it patented. So what you see, this is a Bakri balloon, and this is a simple condom which is attached to the IV IV fluid, uh, IV fluid, and then it is the this is tied at the level of the condom and with the IV set, and then you increase the height to, and it is tied to the saline or a saline bottle, and you increase at the height of 60 centimeter height, and then you push the condom in the uterine cavity and inflate the balloon by putting the starting the IV fluid. And it requires almost 300 cc, and you shouldn't increase more than 350 to 400 cc. I must say that when you put a condom inside, it acts like a balloon, and it will take a shape of the uterus when you put a fluid. So it will obstruct, it will pressurize all the bladder site. This is called a non-inflatable anti-shock garment. The idea is that patient has lost blood, so we want the vital organs to have more circulation compared to the peripheral circulation. So this anti-shock garment prevents the blood flow to the peripheral part of the body and maintains the blood flow to the organs, vital organs. So now conservative surgical management. It controls, if this is not helping, then we have to go to the surgical management, which is divided into conservative and the definite, that is radical surgery. So if the patient is quite okay, then we can go ahead with the conservative line of surgery. But if patient is not fine, you should not waste time in conservative line of treatment. You can straight away go for the obstetric hysterectomy. But I'm talking about this conservative line of treatment because you want to save the uterus where the patient is little comfortable, where you feel you can save the uterus. So let us look at it. What is the mode of action? It controls postpartum hemorrhage, preserves reproductive function, and avoids hysterectomy and related complication and consequences. So you can do some placenta does not come out, then you can remove the by manual removal of placenta, or if the part of the placenta or membrane is inside the uterine cavity and patient is bleeding, then she is not going to stop with your all the medical line of treatment. So every time when the patient delivers, we do at the convexity of our hand, we always look at the placenta and see whether there is missing cotyledon or a membrane or a placenta. If it is there, we have to take it out. That is called as exploration of the uterus. Then Billings suture, that is compression suture, uterine and ovarian artery ligation, that is also called as stepwise devascularization of uterus, internal iliac or what you call as hypogastric artery ligation, and como operation, that is compression of the myometrium, that is village, along with the occlusion of the uterine artery. So it is double serve purpose. Then uterine artery ligation with cervico-isthmus suture it is usually used in a placenta accreta syndrome when the option is only hysterectomy. So this method has come up and we could save this uterus in a placenta accreta syndrome and uterine artery embolization. So let us look at the step-wise devascularization of the uterus. It was reported from Egypt, effective in controlling postpartum hemorrhage in 80% of cases. You can do unilateral uterine artery ligation, bilateral uterine artery ligation in upper part of the lower uterine segment, and then you can bladder, you can push it down, mobilize the bladder, and then you can take the lower part of the uterines on both the side. And if your uterine artery ligation, if it doesn't help, because both the side when you ligate, the blanching should occur. If the blanching occurs, bleeding will reduce. If it doesn't occur, then you may have to go for the ovarian artery ligation. So if you once you ligate the uterine artery, 90% of the blood supply uterus in pregnancy is from uterine vessels. So ligation of uterine arteries result into significant reduction in blood flow to the uterus and hence minimize the postpartum hemorrhage in atonic PPA. So now you can see over in this video that we are just going the cesarean, we have cesarean incision, we have suture, we went 2 centimeter below and midline and the deep. And here we are coming out from the peritoneum and you just tie it. So 2 centimeter below and 2 centimeter deep of the your incision we have done, and it can cause the uterine artery ligation. You can repeat on the other side, and if you go still deeper, you may include ureter. So you have to be very, very careful. Now, ovarian artery ligation, I said that after uterine artery ligation, the blanching doesn't occur, bleeding continues, then you have to go for the ovarian artery ligation. Ovarian artery arises from the aorta, and anastomosis with the uterine artery occurs in the region of the uterine aspect of the utero-ovarian ligament. So here you can see, here we are ligating the ovarian artery, which is parallel to the fallopian tube in the ovarian ligament. Okay, and you can just tie it. Okay, this is we are supposed to do with the instrument, but these videos are the teaching institute video. So we are tying it over here. So both the side you tie bilaterally, and if you can't get over there, then you can take the infundibulal pelvic ligament, which will also obstruct the ovarian artery. So now let us look at the brass suture or Billy suture or the what you call this compression suture. Christopher Billich was the first one who wrote his paper was published in British Journal in 1997, and still from since that onwards, we have gone through many compression sutures. They are modified. The idea is just to compress the uterus in atonic PPH. So once you compress the uterus and the bleeding does not occur, when you're doing cesarean section, it reduces, or from the perineal aspect, when it is vaginal delivery, then only this bleeding will work. So it is a simple, effective, relatively safe, and requires minimum expertise. And I said the bleeding compression suture, if bimanual compression decreases the amount of uterine bleeding by abdominal and perineal inspection, then this is the right patient to do the bleeding operation. And there are many modified chores, Hammond, and they all are equally effective. And after that, many modification has come. So here, what we are doing is that we are doing modifying incision. Cesarean has been done. Patient is having atonic PPA. So original bleach was that they used to do from the uterine cavity, take the stitch, come up and again come back in the uterine cavity to the lower segment and tie. Here we have already sutured the your uterine incision, and the idea is that you take, it should be compression. So one side we have come out, other side we have reached, and the other string we have taken suture, and then we are tying in the fundal. So the idea is just to give compression. Then let us look at the internal iliac artery ligation. Experiments in 1960 by Boschel ascertained that the effect of ligation of internal iliac artery was to convert arterial flow into the venous flows. So what happens? The stasis of the blood occurs, as a result the clot formation occurs, and the bleeding reduces. It is effective in uterine atony, midline perforation, large broad ligament or lateral pelvic hematoma, multiple cervical tears, lower segment bleeding. It is less effective in placental accreta and not useful for uterine laceration. So it should be done by a surgeon. Everybody cannot do it. The surgeon who should be done, the obstetrician who can be doing, who is comfortable in operating within the retroperitoneal space. Clinician must also consider that whether the patient is fit for this surgery without wasting time. As I earlier mentioned, if the patient is deteriorating, you cannot take a extra time for this, because if it doesn't work, you ultimately end up with the hysterectomy. So it depends upon the patient condition. You can go for definite line of treatment. If patient allows you, a condition is better, then you can go for this conservative line of management. So when you do the surgical, this internal iliac ligation, you should know the surgical anatomy. The common iliac artery divides at pelvic brim or sacroiliac joint, or what you call as L4, into external iliac artery and the internal iliac artery. After 3 centimeter, internal iliac artery divide gives the branches as the anterior division and the posterior division. So we have to tie, uterine is a branch of anterior division, so we have to tie anterior division of the internal iliac ligation. There is something called as direct method and indirect method, which I am going to show on you this video. So here we have opened the abdominal cavity, uterus is delivered out and lifted on the other side, and here we are opening the peritoneum between round ligament and the fallopian tube, and we are at the psoas muscle where the external iliac artery is identified. You can see over here external iliac artery which is sitting on the psoas muscle. Now we are going to go upward, trace the common iliac vessel. So for that we have to remove the sheath of this external iliac artery. At the same time you retract the ureter on the medial aspect, and here you can see now when we are tracing, we can see the common iliac artery, and that is your internal iliac artery, and this is external iliac artery which we have traced. Now you have to open the sheath. If you don't open the sheath, your suture will not be proper and your procedure will fail. So now this is a direct method where we are going below the internal iliac artery. right? You can see we are not putting suture, we are just lifting it up and then we'll be putting the suture. So this is a direct method where you are going directly, and this is an indirect method where you are going below the your mixture is going below the common iliac artery. You can see now, okay? And then mixture I'm passing below the common iliac vessel. Why it is, these two methods, what are the advantages, I'll tell you later on. But on the video, we have filled the suture, and now we are going to pass the mixture from the external iliac artery and we will feed the suture. Okay, so now you just see it just sits on the internal iliac artery. Why is this indirect method is important? Because when you go below the internal iliac artery, the internal iliac vein is lateral and posterior to the internal iliac artery. So if you injure this vein, then there is going to be torrential bleed and patient can die on the table. So that's the reason we have shown this indirect method of internal iliac ligation, because below common iliac less likely to injure vessels and therefore indirect method is preferred. So after coming at the internal iliac artery, you can take 3 centimeter below suture, and the sheath is open and you can take the 2 separate suture and cut the suture and not the artery. Okay, so now you should remember certain facts of internal iliac artery ligation. Femoral pulse should be palpated before and after ligation. Absorbable sutures were used to help recanalization after primary exudation, but there is no significant difference is found. So you can use non-absorbable as well as the absorbable. Bilateral internal iliac ligation is necessary and atonic PPH, but when there is a broad ligament hematoma, you can only ligate on that side of the internal iliac artery ligation where the hematoma is found. The reduction of the blood pressure from distal to the ligature. Overall success rate was reported 58% and no adverse effect on subsequent fertility and pregnancy outcome was reported. So after ligation internal iliac artery, collateral circulation will establish within 45 to 60 minutes, and that time the hemostasis is achieved. The complication can be injury to the common iliac vessel, injury to the ureter, central pelvic ischemia, breakdown of the perineal skin, and lower motor neuron damage, because the internal iliac artery anterior division supplies to this tissue, and therefore you can see the complication later on. Now this is a compression suture with occlusion of the uterine artery, which was developed by Dr. Mahesh Gupta from our India, and he said that you should do the compression suture and uterine artery ligation. So what will happen? Double benefit will occur in the atonic PPH. So he had 3 patients, and there he has followed them up, and they found the postpartum, this stitch was very, these combinations very helpful and effective. The postpartum menstrual flow and breastfeeding were normal. Ultrasound confirmed that the endometrium and ureter were normal, and hysteroscopy showed a normal uterine cavity in all 3 women. One subsequent full-term pregnancy occurred after 6 years of this surgery in a 27-year-old woman who delivered with repeat C-section. This was published in our Journal of Obstetrics and Gynecology of India in November-December 2020. Now look at the uterine artery ligation with cervico-ischemic suture, especially when we are dealing with placenta accreta syndrome. So what we do after, at the time of cesarean, we deliver the baby, and before delivering placenta, we ligate both the uterines, and then you take from the cervico-ischemic region a sutures with a straight needle anterior to posterior, come back from posterior to anterior, and on the other side such 2 stitches are taken. And when you are tying these stitches, cervico-ischemic stitch, then you put your dilator into the cervical canal. So when you tie, you don't obliterate the cervical canal. So after that, after time, you can remove the placenta, and it has been reported very, very successful in preserving the uterus instead of going for the definite line of treatment, that is obstructive hysterectomy, where majority of the placenta accreta syndrome end up with the hysterectomy. So now look, come at the role of selective artery embolization, which is found to be in the tertiary care center, in few of the center where expertise are required, and we can do this uterine artery ligation, especially at risk of PPH in placenta accreta syndrome, alternative to obstetric hysterectomy, bleeding persists after hysterectomy, bleeding due to cervical or vaginal laceration. But I want to say that when you have such patient, you should transport beforehand to the such care center. And what we do before taking up for cesarean section, we carry out this procedure of catheterization, and we keep the endovascular balloon closed. And at the time of cesarean section, you find the patient is having postpartum hemorrhage, then you open up the balloon. It will cause temporary tamponade of the internal iliac artery. And in the past, we used to put gelatin, particles which used to block, and that used to get dissolved in 10 days, and the continuation of the internal iliac artery was there. Here, we put an endovascular balloon, keep for 24 hours, then deflate and take it out. The success rate have been reported at 90% with low complication rate. And Ozala et al. Described the patient who had underwent embolization of uterine arteries and averted hysterectomy in close to 80% of the cases. So this is also really helpful, but one should know it is available in the specialized tertiary care center, and specialized are needed. But if you do this the arterial embolization when the patient is bleeding profusely, then you should not go to that radiotherapy, radiotherapy, radiology department and do such procedure. Then you must go definite line of treatment. But if prophylactic you can do, and after your hysterectomy she bleeds, then you have no choice but to do this procedure. Obstetric hysterectomy, it is a final definite line of treatment. It is the fastest procedure in an emergency to control postpartum hemorrhage. It has been reported 10.3% in PPH cases. Indications are failure of conservative surgical procedure. Again, I am repeating, you cannot do conservative surgical procedure unless patient gives you time, and unrepairable rupture uterus. Indication for subtotal hysterectomies are atonic PPH and rupture uterus, but you may have to proceed with the total hysterectomy to control bleeding from lower segment of the uterus, cervix, and vagina. Now, management of traumatic PPH. The uterus is very well contracted in spite of that patient is bleeding. So you have to explore under anesthesia. There will be lower genital tract injury, suturing vulval, vaginal paraurethral tears after catheterization, cervical tear suture in cervical tear, and vaginal packing in cervical laceration. Remember, when you find a cervical tear with the 3-sponge system, sponge forceps system, and if you can't find apex, because you have to go above apex, if you can't find apex, that means the injury tear has gone into the lower uterine segment or the upper uterine segment. Then immediately you explore, and if you don't tie the apex, cannot go above apex, the bleeding is not going to stop. So you have to explore the you have to take patient for the laparotomy, and whatever injury you find, you suture it. Sometimes in the rupture uterus, you are not in a position to suture, then you have to go for the obstetric hysterectomy. If you find internal iliac ligation, broad ligament hematoma, you can go internal iliac ligation. Total hysterectomy may be necessary in controlling lower segments, cervical, and for nasal tear. Secondary PPH occurs due to infection, retained placental fragments, sub-involution of the uterus. So management is you have to give high antibiotics and uterotonics, exploration in retained placental fragments, uterine artery embolization in uncontrolled bleeding after ruling out gestation trophoblastic tumor, and hysterectomy. So to conclude, PPH is a serious life-threatening obstetric complication. It is a major cause of maternal mortality and morbidity not only in developing world but also in the developed countries. It can be anticipated, prevented, and treated. Increased obstetric care decreases the postpartum hemorrhage related to complication and consequences. Being a Secretary General of FOXY, I know there are many projects going on the maternal health, and I am very, very happy to share, and everybody knows that we could reduce the maternal mortality of our country by 97 per 100,000 live births, which is very, very remarkable. And for this, I give credit to not only government policies, but also the organizations like FOXY and our grassroots level workers who are delivering this patient. I really give credit to them. And we have many projects in FOXY. We have emergency obstetric care, where in a rural setup we train the medical officer into the cesarean section and other, part of this how to manage this condition like PPA. And we have a FOXY Manyata certification courses because 35 to 40% of patients deliver in private sector, and those the whatever government policies are there, they come into the public sector, but the private sectors are not, they are not they are not getting these facilities. So we started a Manyata certification course where we enroll all the private practitioner as a whole, as a unit. That the doctor is there, obstetrician, paramedics are there, and we train them, and they are, if they 85%, they pass, then the certificate is given to them that this is a good center to deal with. And secondly, we have also tied up with the NAB, that is, and they have done 100 facilities, certification course, certification they've given, and we are going further 100. So we are doing many, many such projects of reduction in maternal mortality rate, especially postpartum hemorrhage. Even the FIGO, we are also doing what you call a leadership development initiative, and we are also doing many, many PPH, projects, especially where the maternal mortality rate is high, especially Uttar Pradesh, Bihar, Assam, and East states, we are doing. And we have got very big another project from Bill and Melinda Gates for, doing in these 4 states. So we are really happy to have this, and we are very happy that all of us are working for the reduction in maternal mortality rate because we are all committed to women's health. So reset, refocus, readjust, restart as many times as you need to. Just never give up. Let's ensure no mother dies of postpartum hemorrhage. I thank all of you for the patient hearing.
Thank you so much, ma'am, for your wonderful presentation. So, ma'am, we do have some questions from our audience if you like to take that up.
Sure, sure.
Yes, ma'am. So, ma'am, the first question from our audience is: how does the management of postpartum hemorrhage differ in resource limited settings compared to well resourced environments?
See, in a low resource setting, we have Anganwadi auxiliary midwives, they are screening the patients, especially auxiliary midwives. And if they find these are the high risk patients, they don't wait till the patient goes into labor. They refer to them to the tertiary care center. And as I have mentioned, the misoprostol is given to this patient, then once they deliver, they can, take that tablet orally. So in low resource setting, if the auxiliary midwives are available, we can have the normal, prevention of postpartum hemorrhage, those strategies like starting oxytocin drug, control contraction, argometrin if the oxytocin is not available, and we can give misoprostol. But in urban center where all the facilities are available, we can do all the things including, conservative surgical method, definite line of surgery, that is hysterectomy, and if facilities are available, arterial embolization. So when in a rural area, you how to diagnose, you how to say that this is a high risk and refer to the tertiary care center.
Thank you, ma'am. There is one last question from our audience. What are the key consideration in the postpartum follow-up of patients who have experienced postpartum hemorrhage?
No. So very good question. That these patients are admitted when they have a postpartum hemorrhage because we have treated them by medical line or conservative surgery or definite surgery. So we have to follow because they are going to be anemic. They're going to be lactational failure. So we have to motivate them because once if they have a hysterectomy, they are depressed like anything. So that depression part also should be taken care. So anemia should be treated. Nowadays we believe that if the patient is anemic, not only postpartum hemorrhage patient with postpartum, otherwise also we give one IV, iron. So when she goes home, she is absolutely fit to do her routine work with her baby, can look after the baby, and at the same time, if by chance she conceives, she doesn't use contraception. We motivate them for contraception. By chance she does conceive, then she is not that anemic when she conceives. So postpartum period, you have to look after her physically as well as mentally. You have to be very, very careful with her because she is likely to go into depression. At the same time, you treat her anemia by IV iron, and at the same time, you give her a good food because lactation failure are likely to have. So let her have a good food and motivate her for the lactation, breastfeeding. This breastfeeding will, once the baby starts sucking, then the breastfeeding, the reflex occurs and she can definitely produce the good amount of milk. So these are the care you have to take. And at the same time, you have to counsel to the family members, especially husband, when she ends up with the hysterectomy, and the mother-in-law, because they are also should be supportive to her. So from all respect, family members and we as a doctor should be supportive to her.
Thank you so much, ma'am, for answering all our questions. Before concluding today's session, ma'am, any last remark from you?
We last remark is that we are going towards the sustainable development goal. By 2030 our maternal mortality rate should be less than 70 per 100,000 live births. And let me tell you, many of our states, Kerala is always first number. Kerala, Andhra Pradesh, Telangana, Tamil Nadu, Maharashtra, Gujarat, we have, and Jharkhand, we all have we achieve this goal of less than 70 per 100,000 live birth. So I request all of them, all these states, to by 2030 the maternal mortality rate in their state at least should go single digit. And where the maternal mortality is high, those states, they are working towards reducing the maternal mortality rate. And postpartum hemorrhage, as I said, 35% of the postpartum hemorrhage maternal mortality occurs. 20% of us, our India contributes to the maternal mortality due to postpartum hemorrhage. So if we can prevent anemia, if you can treat them, right from childhood, prevention of anemia, I will say from womb to childhood to adolescent, which we have many, many, programs. Okay, during pregnancy, if we can prevent anemia, majority of the postpartum hemorrhage will be prevented. And therefore, because the anemia gives rise to not only PPH but also other condition like abortion, abruption of placenta, PIH. So important, very important is anemia treatment and prevention. And then high risk patient should be transferred to the tertiary care center or a secondary care center where all the facilities are available for to deal with such situation. So we can reduce the maternal mortality rate as well as the maternal morbidity. So these are my conclusion part. I can again say, okay, these are the last things we should go ahead and do the needful.
Thank you, ma'am, for joining us today.